So welcome everybody to this panel session in Value in Health Week. It's a twilight session, so I appreciate everyone's attendance. For those who've had a long day at work, for those who cross time zones to be with us or have other challenges on their time, welcome to this panel session. So this is my privilege to chair. My name is Sue Goodfellow. I am the clinical improvement lead for the value-based healthcare team. I also work as a GP in South East Wales and have done for the last 27 years. The focus of this panel discussion is patient perspectives on why better data is key to patient-centered care. This is a really important topic and hinges on patient engagement, patient knows best, and getting patients involved in their care in the way that those of us who work with patients and as advocates for patients know that is wanted and needed. I need to first of all give you an apology. One of our speakers that was in the programme, that's Dr. Natalie Joseph-Williams from Cardiff University, has been unable to join us, unfortunately, for reasons beyond anybody's control. And so she sends her apologies and hopes that she'll be able to join another session in Value in Health Week on a different occasion. So unfortunately, we're without Natalie, who has done work in shared decision making. I just wanted to say from the synopsis of the session also that it does say that there are patients on the panel, and this evening there are no patients, but we do have three experts in patient advocacy and patients who work, clinicians who work with patients using patient data, and they have very great insights into the use of patient data to inform and improve care. So I don't think you'll be disappointed, but I wanted to make that clear. Now, because of Natalie's absence, I was asked to give a GP perspective on what I thought about use of patient data to inform their care. And I'm conscious as a chair that my job is to be neutral, so I'm slightly uncomfortable about this. So I thought I'd just mention a little patient story, one that's been repeated many times in my experience. And that is when patients are given the dilemma of outpatient attendance when perhaps they feel they may not need to attend. And just as an example, I would have a patient come into my surgery in a routine appointment and take out of their handbag or their pocket several outpatient invitation letters for the same hospital, all within a short space of time. And the reason they've made the appointment with me is to say to me, I need your advice on whether I need to go to these appointments or what I should do, because really, as far as that condition goes, I'm absolutely fine. And my neighbour has been waiting for an appointment for that clinic for several months and just makes me wonder whether I should really take up that appointment. And this is something that I hear frequently, and anyone else who works with patients or indeed as a service user of the NHS may feel some resonance with that story. So I just wanted to make that challenge that surely patient-centered care starts with focusing our resources where patients need them and when they need them, and that must be the start of the patient pathway. And everything else would be improved just from that simple point. So that's the challenge. That's all I want to say, because I know that our expert panelists have a lot of insights to give us, and I don't want to take up any more time for this hour-long session. I invite you all, please, to pose your questions to our panelists as we go through this session. You can put them into the meeting chat, and our moderators will try and highlight them so that I can put them to our experts either during the hour or towards the end of the hour. So please get involved, ask your questions while you have the opportunity to have these three experts with us. So just to give you a brief overview of who we have in the room this evening, we have Wayne Lewis, who's the policy lead for Wales for the charity Colitis and Crohn's UK and has many years experience in this field. We have two clinicians, Dr. Clea Atkinson, who's a consultant in palliative care, and her colleague Sian Hughes, who's a palliative care specialist nurse, both of whom work within Cardiff and Vale Health Board and who are currently spreading their work to other health boards within Wales. So we welcome all three of our panelists, and I'm very pleased to start by welcoming Wayne, who's got a slide presentation for you. And thank you, Wayne. Over to you.
Okay, thanks very much. What I'd like to do is just to sort of do a gallop through really the look at seeing patients as partners in data collection, and I've drawn some some bits and bobs from everywhere, really, in order to provoke conversations and to provoke thought, if that's okay. So if we could have the first slide, please. Okay, in terms of Crohn's and colitis, UK, we are sort of committed to three main pillars in terms of data. First of all, it's about the individual. So if we can individualize treatment for people, then that would be a major step forward. And so as an example of that, last week we were involved with a consultation with NICE on the PredictSure prognostic test that's going through the paces at the moment, and we actually put some charitable resources into funding the basic research behind that. So looking at individualizing treatment is key to the charity. Secondly, the use of sort of bigger data, along with the BSG and the Royal College of Physicians. We are partners in the IBD registry, which I think is the biggest registry in Europe, and as you can see there, with over 67,000 patient records in there. So there's a sort of bigger look at data, as it were. And the third one, we're also committed to using existing data. And I think this is really important because we're always searching for how treatment could be improved for people. And there is data out there that will improve treatment. So going back about a year, we and Welsh Government pulled together the first meeting, all Wales meeting of clinicians to look at IBD. And as part of the lead up to that meeting, we sent out a questionnaire and asked the health boards to tell us how many people they had in their health board with IBD. Well, it may surprise some people to know that none of them knew how many patients they had. They were all basing their guesswork to a degree. Hello, you? Yeah, the screen went black. Are we back? Yeah, okay, thank you. What we did is we talked to the SAIL data bank. For those of you who don't know, that's based in Swansea University, with SAIL standing for Secure Anonymised Information Linkage. And they have access to very large amounts of data, including all revenues and customs data and stuff like that. They also have 80% of primary care practice data sets. So we asked them to look at the number of people with a confirmed diagnosis of Crohn's or colitis. And they were able to do that for us. And even from that basic sort of examination of the data, they were able to come up with a prevalence rate of 1 in 117 rather than 1 in 250. So even if health boards just plan on that new figure rather than their existing figure, then that should improve services, assuming they put money behind the services. So there's those three levels: individualized, the bigger data, and existing data.
Thank you for that, Wayne. Could you just tell us now, you've shown us the three levels at which you use patient data. Can you tell us what the general patient view is of patient-related outcome measures and how they look at that?
Yeah, certainly. Next slide, please. And well, I'll just a quick comment on that. From our point of view, data is absolutely crucial to person-centered care, and person-centered care is crucial for accurate data collection. That's a crucial connection, I think. Next slide, please. Right, in terms of PROMs, I was in a meeting with a gastro who was talking to a patient about PROMs, and her question to him is, well, what's in it for me? You know, why would I fill in a PROM? How will this improve the treatment I receive? I think the crucial thing that she said is that, and that hence the tongue-in-cheek graphic on the right, is that no patient actually wants to go to hospital. I'm sure you clinicians are lovely people, but we don't actually want to come and see you if that's at all possible. So how do PROMs help people keep out of hospital, essentially? Now, some people have a better idea of how to use PROMs than others. Next slide, please. So Tesco's use their purchase optimization measure, or a PROM. So let's assume you were going shopping in Cardiff on Thursday, but before you went, Tesco sent you a little message saying, can you tell me how many Gala apples you intend buying? How many Brayburn did you buy last week? What price are you prepared to pay? Do you want them wrapped, unwrapped? Will you be paying cash, card? Yeah, any questions for staff? By the way, there's no free text place for you to ask those questions. Oh, and in small letters, they'll say, this data won't help your experience in shopping in Cardiff, but it will help us when we open our new store in Luton. Now, if that was a PROM that we had to fill in before we went to Tesco's, I suspect that very few of us would fill that in. Okay, next slide, please. Yeah, so I would say Tesco's have got PROM sus because they make it very simple for you to give them their data. You don't realize you're giving it them. They link their questions to your personal situation. You give that information to them regularly. They feed back to you regularly. They use that to improve their services. And yeah, they get all that for about the price of a turkey at Christmas. That's what I use my points for anyway. So they make it very, very easy. You don't realize the data you're giving them. What do we do, I suppose, is, you know, in the NHS? Next slide, please. Right, we are, as Crohn's and Colitis, committed to the increased use of PROMs, and we're very familiar with the IBD control PROM. But if you look at that and compare it to Tesco's, do they make it simple? Well, yeah, that's pretty simple to fill in. Link the question to your personal situation? Yeah, they do that. You don't realize the info? Yeah, you do realize you're having to complete that. Do you give them the info regularly? Well, you may do. It depends on whether they send it to you in advance often enough. Do they give you feedback? Yeah, just leave a question mark there. And then that big question there is that info used to improve their service to you? No, I don't know is the answer. But if you look at question 4 on that, you're invited in that PROM. It says, and I'll have to read the small print myself here. At your next clinic visit, would you like to discuss alternative types of drugs for controlling IBD, ways to adjust your own treatment, side effects or difficulties in using your medicines, new symptoms that have developed since your last visit? Those are entirely clinician-based questions. There's nothing in that PROM that will enable a patient to tell you as clinicians what is worrying them, what is important to them. And I'll give you a sort of a classic story. We have a young woman with Crohn's who was pregnant and was very, very worried about this. And she'd waited for her outpatient appointment. She went in and she emerged after the appointment in floods of tears because there had been absolutely no chance offered her to have a discussion with the clinician about that key issue to her. She was pregnant, she had Crohn's that was flaring, and just no opportunity was given to her to discuss that. And I think when we develop PROMs, we need to think about what is important to the patient. Okay.
Wayne, can I just mention, I think that's a really important point and is already got some resonance with somebody in our audience. I'm sorry, I don't know the name of the person who's posted this question, but I just think it may be an opportune time to just mention this. So someone anonymous, a frequent patient, but who also works for the NHS, issues in several health boards the same. Do you think there would be any value in a patient feedback app, which is standardised across Wales, encouraging patient constant feedback? What is important to patients isn't always what clinicians think is important, which is exactly your point, but would actually help patient experience and the time they have to spend in hospital. For example, food choice, who was listening and gave time, patient views on their pathways and time scales. So this is a wider question on not just clinical care, which is exactly your point, but the whole experience and the whole impact on the patient. I wonder if you could just respond to that question from the audience for us.
Yeah, I suppose my thought would be, as with any feedback, it depends on whether the recipients of that feedback are willing to act on it. Because if it's too general, then it becomes nobody's responsibility. If you just feedback generally, I think feedback is probably best given to your team. For instance, in terms of IBD, giving feedback there, and funnily enough, we have just had 10,000 patients give feedback on IBD through a patient survey. So yes, the answer has to be yes. Feedback is really important from patient. It's a crucial feedback, I think, but it does depend on those people those people who receive the feedback acting upon it, and you need buy-in from the health boards for that.
I agree, and thank you for that, Wayne. That's a good answer, and thank you, Sarah, for that question. So please continue with your slides, Wayne, and give us some more of your insights into the use of PROMs and collaboration with patients using their data.
Okay, next slide, please. Just a quick one. I suppose summing it up, if you put the patient experience at the center, the data will follow, and I think this is key to us, because I think we often see or hear of patients being seen as sources of data, almost like a mine that you can mine, whereas really, if you put the service and look at how the service is structured and how that serves the needs of the patient, the data will fall out the back of it. You shouldn't have to go trawling for data, really. Okay, next slide, please. Okay, I just wanted to mention a recent example, and I had hoped to show 2 video slots here of 2 clinicians, Professor Stuart Bloom from UCL and Nick Kennedy from the Royal Devon Exeter, but technically we can't. But you'll find on one of the slides here, and people are welcome to get this link. You'll find a link to their work, and it's well worth listening to it. It's only about 15 minutes, but it's worth a listen to. Okay, next slide, please. Right, linking IBD to COVID. As you know, when the pandemic sort of hit, and with lockdown and whatever, the shielding strategy came about, and the NHS were asked to identify those in the highest group. Now, in terms of the BSG, that group, those on immunosuppressants, included people with IBD. Now, when the BSG saw this request, they realized that there would be limitations in asking the services to be able to stratify their high-risk groups. So, to cut a long story short, what they did was they developed a risk tool which asked patients to enter their data directly in order to stratify risk. Now, that risk tool was publicised and went out on our website as well, Crohn's and Colitis UK website, and over 34,000 patients entered their data. Now, part of the reason for the concern that lay behind this with the government and with the NHS was those people who fell into the high-risk groups were eligible for drugs deliveries and also for food deliveries. So there was both a health and an economic worry. So there was a concern when the BSG suggested patient-entered data being used. So, as I say, 34,000 patients entered their data, and later on, the 2 lead clinicians, which were Stuart Bloom and Nick Kennedy, went back and looked at the patient-entered data and compared it with the hospital-entered data in 10 hospitals across the UK. Now, I'm no statistician, but the Cohen's kappa was 0.89, which I understand is remarkably high and indicates almost perfect agreement between the 2. So that came as a real surprise, I think, and a pleasant surprise to those people who were involved. Nobody tried to game the system, and the patient entered data was very accurate indeed.
Wayne, I think that's a really important point you make. It's an important point you make because you may be aware that the risk stratification has caused some concern and some controversy because of the way the data was collected, and there was concern that some patients received shielding letters who didn't need them, and patients who didn't receive them who perhaps should have. So like any large data trawl, there were some errors there. And I think what you've mentioned there in using patient-reported data, I think is fairly groundbreaking, because in fact it's not about secondary gain. It's about trying to give information that is relevant to individual patients, and I think that's really useful in encouraging perhaps that type of data collection in future. Let's hope we're never in the same position, but on a smaller scale perhaps. You know, that I think that would be of interest to our listeners to hear that patients are very accurate, in fact, in putting in their data and risk stratifying themselves. And indeed, the statistics show that. So thank you for that insight. I think that's helpful.
Yeah. I would urge people, if we go on to the next slide, please, Alistair, the link there, the Tillot's link, is the one that will take you to Stuart Bloom and Nick Kennedy's input. It's a webinar pulled together by Tillot, and right at the end, their last section, I think it divides a 20 minutes video up into about 7 separate sessions, but their last session in there is them saying how convinced they are that patient-entered data should play a much larger part in this type of research in the future. So that, you know, they are convinced by their experience, and they're writing a paper on it, which should be published soon, which should be interesting. Okay. So I guess what I'd probably like to move on to is what did we learn from that, I guess. So next slide, please. Yeah, I guess, you know, did we learn it, or was it restated? And that is that if the patient sees the relevance of the information you're asking for, they will engage. And when they engage, as Stuart Bloom and Nick Kennedy will confirm, you can be confident in the accuracy of the information you receive. But when you as clinicians have the information, you need to do something with it that's relevant. The patients need to see that you've done something relevant to them. And I'll give you an example here. We have a guy with Crohn's who is a patient here in Wales, and his health board apparently worked with a specific app. And so he was encouraged to fill that in. So he filled it in dutifully for 3 months, turned up without patient's appointment, said, you know, right, well, I've been doing that, and was told, we don't look at that data. Now that's just not good enough, you know. It has to be said, if you're going to collect data and patients are going to commit to it, then you have to use that data and be seen to be using it to improve the service. And as I say in that little whatever you call it at the bottom, the little design there, relevance of data. The relevance of the data collection will breed engagement. The engagement will breed the accuracy, and the tangible use will breed the long-term commitment to supplying that data.
Wayne, can I just ask you a second whether you think timeliness is important in that flow diagram there? How quickly do you think that people who collect patient data need to feed it back to make it relevant and improve engagement with patients? Well,
I think, you know, it depends. If we use the example, if you've got a fluctuating condition like Crohn's, if you're feeding in data that says, I'm okay, I'm not flaring, I'm okay, I'm not flaring, I'm okay, I'm not flaring, on whatever it is, a weekly basis or whatever, then feedback of just an acknowledgement would be fine, I think. But then if suddenly it flares and you enter that data, the expectation is you would have feedback almost immediately. And I think that is the issue. If we're moving, and we'll come on to talk about apps, but if we're moving towards remote monitoring of conditions, then you have to be able to respond quickly. For people to have faith in it, you need to know that when you're poorly, somebody will get back to you. So timeliness is important. And I think it varies according to, you know, where your condition is. If you're okay, it probably doesn't need that regular. But if you're flaring, it needs almost immediate feedback.
Understood. So where are we now in terms of patient engagement with data provision, in your opinion?
Okay, next slide, please. I would say that remote access, as I say here, access input monitoring has acquired a much wider level of professional and societal acceptance post-COVID. I know I was speaking to people in the value-based healthcare system prior to COVID, and we were just edging towards this. I then went on furlough and came back, and it's like the world had changed. And well, it has changed, that's for sure. And I think that's great because it's advanced. We've got over a lot of hurdles that would have been there, I think. So if there is they say never waste a crisis or something, there are advances have been made as a result. So we've got to look at the positives there. And I think some conditions, IBD, I would say, wouldn't I, lend themselves to remote monitoring and remote access because they are fluctuating conditions. And one of the things, going back to Stuart Bloom, he will say that patient-entered data in terms of scoring their condition is likely to be very accurate and would prove very useful for him as a researcher. So I think there are conditions that lend themselves. Society and the profession is willing to look now at remote monitoring. So I think we've advanced in the last 6 months substantially. And if the apps or whatever are correct, then that gives a real chance for the patient voice to be heard very, very clearly.
Mm-hmm. There's been a pre-submitted question actually from the audience on the issue of apps, Wayne. I wonder if you could address that for us as well. The question was submitted before the live session was, how do we ensure patients have access to ever-changing apps and phone platforms, etc.? Is there one size fits all, or do we need to be more flexible? Your views on that, please.
I think it's definitely not a one size fits all. There will be people for whom apps work, and I think it's there's usually this cozy answer of age demographics, it won't work for older people. I don't think that's right. I think there are a lot of older people who are quite happy to use apps, so it's not as simple as that, but there will be people who can't use an app or don't enjoy the experience of remote monitoring. So there will be people for whom remote monitoring, remote access doesn't work, and we need to work out the solutions for them. So there's not one size fits all, but I think there are more options available now than the standard 6-monthly outpatient letter dropping through your letterbox and then turning up at your GP with 3 of them saying, go on, tell me which one I'm going to.
Fair enough.
I think there's one key question now, and this is probably my last slide. I think if you could move on to the last slide. And that is, is the NHS willing to see patients as partners and also to reconfigure services? Because there is an opportunity here to reconfigure services. We can stop people going into hospital or go into hospital for outpatients who don't need to go. I've had a gastro sit down with me and said, I am fed up with patients coming to see me, and we just have a chat about how bloody awful the parking is. That's not a good use of resources. So if the NHS is willing to reconfigure, you can have community-based IBD nurses who will monitor people out in the community. They won't even need to come anywhere near a hospital, and then that frees up space in the outpatient departments for more of a ready access for people who are ill. So sorry to say, for the clinician's point of view, your workload won't go down, but at least you'll be seeing ill patients.
Mm-hmm. Do you think, Wayne, that needs a culture change?
Yeah, it's not the one size. I know there are clinicians out there. I speak to IBD nurses who would jump at this, tomorrow, the reconfiguration. And there will be probably some people who are quite comfortable with the current system. So it needs a good drive behind it, because it does need resources and it does need a commitment to a different type of working. Yeah.
And it seems to me that this would be an opportunity for co-design with patients using the data that you're suggesting here. Yeah.
I think I haven't come across a system that hasn't been improved by a patient input.
I think that's a great insight from you, Wayne. Just to complete your presentation for now, we will be back to you later with more questions, perhaps in the Q&A, but you have answered a few as we've gone through. So many thanks for that insight. We're now going to switch over to Dr. Claire Atkinson and Sian Hughes to present on their data and their insights on their work, patients living with heart failure. So over to you, Claire, if you want to start your presentation.
Good evening, everybody. So going to talk today a little bit about a new initiative that we began about 4 years ago to try and improve the access to the palliative approach for patients with advanced heart failure. Next slide, please. And the reason for this is because the trajectory of patients with heart failure varies a lot depending on where they are on the journey. So at the beginning, there may be a period where they don't have symptoms, where there's lots of potential to perhaps hold up the progress of the heart failure by early diagnosis, and then bringing in many new methods to increase survival. And so there are drugs that can be used, ACE inhibitors, beta blockers, etc., cardiac resynchronization therapies, new things, Entresto, etc., which the heart failure specialists are using to increase survival. But the problem is that the last phase of life wasn't really being managed in a way that so expertly addressed what was happening at that phase of their illness. So we essentially were recognising that these patients were highly symptomatic, coming in and out of hospital frequently in the last 6 to 12 months of their lives, and that the cardiology teams were not finding this very easy to manage. Patients were very symptomatic, and that this was very costly to the NHS, with 50% of the costs of heart failure being spent in the last 6 months of these patients' lives. And when in the knowledge that 2% of all NHS funding goes on heart failure patients, a lot of money was being spent there, and we weren't really sure that these patients were getting what they really wanted. So that's where we began.
In 2016, we started to work with heart failure patients and the heart failure team to develop a palliative supportive care service with those with end-stage heart failure. Oh, sorry, the next slide. And the starting point was exploring with service users what they wanted from services, and then trying to design services to match these, rather than service users fitting in with static service models. What do these patients want from healthcare? They actually want adequate pain and symptom control, an achievement of a sense of control, a relief of burdens of others, and it was really important for them to strengthen relationships with loved ones and avoid inappropriate prolongation of dying. And that's what the literature was telling us, but that's also what we were hearing from patients. That's right, yeah. Relief burden on others. Advanced slide. Strengthening and avoidance of inappropriation, prolongation of dying. Next slide, please. This is a service model that we currently use to design to meet patients' needs, and we constantly refine it according to patient feedback. Service users and carers were constantly consulted during the development of the pathway. So by listening to them and exploring their goals of care alongside what was happening in practice, we developed a cross-boundary co-speciality pathway that was then implemented with the heart failure team and in liaison with primary and acute healthcare teams and other stakeholders. After referral, patients are discussed at the MDT. Key aspects of this are that it's co-speciality and multidisciplinary. And we found that by talking to patients, that's actually what they wanted from services. They developed good relationships with the heart failure team and wanted to maintain that at the same time whilst we were getting to know them and build a rapport and understand their needs. Service delivery follows a flexible format with a strong focus on this compassionate relationship building, with exploration of the patient's understanding of the situation and really trying to find out what matters to them most. Was it symptoms? Was it care needs? And what aspects of healthcare services they wanted to engage with. We then provided a mixture of symptom control, future care planning and psychological support. And communication and coordination of care was also intrinsic to this care delivery, and discussing with patients how they wanted to engage with us and what were the best formats for them. And that's really how the supportive heart failure service developed, was working alongside patients and colleagues and finding out what met their needs best. Next slide, please. The success of this pathway was achieved by listening to patients, and by listening to them, we found that it was very motivating to hear their stories, and also measuring patient reported outcomes really gave direction to how the service should develop. Both formal data collection and service user stories have been used to inform service development. Also being flexible to allow services to evolve that meets their needs. Listening to patients was motivating and enabled the services to match the patient's needs. We found it extremely influencing and a good way of addressing some barriers. And the most important, well, one of the noticeable things that was said to us was about service users were repeatedly saying, please keep me out of hospital. And so by coordinating information giving and liaising with community teams, we tried to make this more achievable. And then, the next slide, please. During COVID, this group of service users were shielding. Most had been discussing with us how the risks to their health were changing before the initial lockdown period, but we knew that we needed to remain engaged and support the patients in the most effective way and find out how they wanted to engage with services. So during routine phone reviews, we asked them how they would like contact to be maintained. And these graphs kind of show what the answers were. Initially, the first bar chart shows before the end of June when lockdown was on, and everybody, well, over 90% of the people that we were ringing up and discussing their needs were actually saying we'd prefer remote contacts. And then if we look at after July onwards, again, it was majority of patients were wanting to be contacted and reviewed over the telephone. But by that time then, there was a few more that were actually saying, will come into clinic if it's clinically appropriate. So they were actually wanting the phone screening, but then would also attend hospital if needed. And it was very much patient-led and patient need. The other thing that we asked about at that time was about the preferences for preferred place of care. And again, what happened there was when we were asking about preferred place of care, service users were really saying that they wanted to stay at home, but also they were saying it depends on the course of the deterioration, and if there was a clinical deterioration with some reversibility to it, that a period in hospital would bring meaningful benefit to them, they were then willing to come into hospital.
Thank you, Sian. I think those insights into COVID-specific changes in your service are really interesting, and perhaps Sian and Claire, between you, a couple of things that come to mind from my point of view here that may be of interest to the audience. Do you think that's the basis of a triage model with telephone first to decide on a prioritization that has come about because of COVID? Is the first question.
Yeah, definitely. I mean, we knew that there was some preferences before, because when we were evolving our service, we were asking patients that, and also it was becoming apparent that different patients had different functional levels, and so depending on whether it was routine reviews that they wanted or were less well and were prepared to come up and see us in clinic, that became more exaggerated during COVID. So it was just a really good opportunity to review really what patients wanted and how we could deliver that to them in the most resource friendly way we could.
Yes, and another question that's come in from in our messages is to do with the type of PROM and tool you're using. So did you use a validated PROM that was in existence? Did you develop your own? And the specific question is, in Cardiff and Vale, is there a digital tool being used to support heart failure patients to improve communication and provide remote care planning? So could you address that question for us?
So in terms of, is there a digital tool? Currently not.
Yeah.
But it's something
Right.
that we're aware they're using in some centres in London, and which we're about to start looking at. But how we're going to do that, again, really referring back to what Wayne was saying, making sure that we're actually making it appropriate for patients and not actually what we think patients want, is really important. So, you know, we know that there are things out there. We'd be keen to use them, particularly as our service is growing bigger and bigger. But currently, no, we're not.
So you'd be planning to build on existing expertise in that area and add your expertise to it rather than starting reinventing the wheel.
Yeah.
Is that right? Yeah.
Absolutely. But also we're not sure that it's exactly how we'd want it. So we've got the opportunity to improve on that. And in terms of what tool, so obviously we're aware of some PROMs that are being used across heart failure, but there was we found that when we were trying to use those tools, they weren't really fine enough or sensitive enough to the patients that we have. We have such extremely symptomatic and poor functional level of patients that when we're looking at, for example, symptoms, we weren't able to delineate very well how much we were it was very difficult to show how much we were improving things for them. So we did evolve a tool for our patient set, which was included a questionnaire that we sent out to all of our service users at one point in time, and we got a 90% return rate, over 90% return rate from that on one shot postal questionnaire. And that showed us much more what we wanted to know, really, whether patients felt our service was giving them what we hoped they were getting, which was improved symptom control, better quality of life, whether it was supporting them and their carers, whether they felt it was compassionate, and also, very important question, would they recommend it to someone else in their position? And over 95% of people said that they would.
So the user friendliness of a device is important in your experience. Another question that's just come in, which seems to be linked, it's not quite the same as a PROM, but it concerns the use of apps and wearables for collecting patient data. And do you see a place for that in your service?
I think definitely there's a place for an app, and we have looked at that and talked about that. I think I'd say the same as Wayne, really, is that, you know, it's very variable. You know, you think maybe older people might not be able to use them, but I'm sure they could. But equally, there are younger people who wouldn't. So it's not one size fits all. And but we've found that in the whole evolution of our service is that we have to provide a bespoke service to our patients. And in actual fact, if we do that, we get much higher patient satisfaction. And patients, you know, they don't take advantage of that. They respect the way that we're trying to manage the service for them. And so, you know, if they can come up to clinic, then they will. And they only ask us to do home visits if they really, really need us to. And, you know, and also they will report to us and tell us if things are changing. We don't have to ring them all the time. They work with us because they understand that, you know, we're trying to do the best for them. And so they reciprocate and help us.
I think that's very useful to hear that both you and Wayne are in consensus there about some of the aspects of what matters in terms of gathering patient data, but also that once you've engaged your patients in this, that the authenticity of the data is not in doubt, and it's so useful and so good to hear that, because although I don't doubt it, I think there are others who are more worried about using patient data in this way, and particularly with all the GDPR aspects as well. It's a whole other subject, but thank you for that, and I'll let you carry on with your presentation, Claire. Thank you.
Okay, next slide. So this just is to demonstrate how we evaluated our service. It can be quite difficult to evaluate cost effectiveness, as I'm sure everyone knows. But so the pink arrow demonstrates the point at which the, patients were being referred to us, and in the top right hand corner is the sort of loose referral criteria, although mainly we were looking for expert opinion, because that seems to be one of the best ways to determine if a patient's ready to come to supportive care. And then we looked at 1 year before the point of referral and 1 year or up to the point of death for patients within our service. And on average, patients were with us about 2/3 to 3/4 of a year. And underneath you can see the things that we were providing to the patient. So compassion-based rapport building, as Sian has mentioned, symptom control, gradual advanced care planning, access to palliative services like hospice, and also giving subcutaneous infusions of diuretics in the community were all elements of what we were providing. So next slide. So this shows 4 years of data, and essentially the yellow columns show hospital days spent before patients were referred to us, and purple after. So in patients who are deteriorating because they are, you know, by their very nature heading towards the latter stages of their journey, to see that the orange column is bigger than the purple in itself already says that we're doing something successful to help these patients remain where they want to be, which is at home as much as possible. And we're particularly making a difference in that in heart failure related reasons for admission. And what's really important is that as we're going through the years, the 4 years of service evolution, where we've been listening to patients and what they want and evolving and changing our service and remaining flexible to them all in a bespoke way, we're getting better and better at keeping patients out of hospital. Next slide, please. So this slide just demonstrates on the left, as I was mentioning, the patient feedback questionnaire that we did, demonstrating high numbers of the patients would recommend the service, and really that all the things that we hoped to provide, we were providing. So we knew that they wanted better symptom control, and high numbers of them were reporting this, even though symptoms in advanced heart failure are very difficult to manage often, that they were saying that quality of life was improved, even though quality of life can be very poor, but also that we were helping them feel listened to, that they could discuss how they felt, and that we were supporting the people that they love, which we know is important to them, and helping coordinate care. And of course, very importantly, that 95% of patients felt that the care was compassionate. And on the right, just I was alluding to before, very important for patients who want to remain at home as much as possible. And linked to that is the desire for people generally. And in the left-hand pie chart, you can see that 81% of the general population, if you ask them, would choose to die at home by preference. But when you look at the advanced heart failure patients, this is actually often only 81% of patients die in hospital. So the middle pie chart shows how we've managed to impact on that and reduce an average of 81% dying in hospital down to 32%. and many more patients dying at home as they would choose. And in the patients where we give subcutaneous furosemide infusion so that patients don't have to come in for intravenous furosemide, we're managing to achieve even higher levels, 91% of patients dying at home, and a small portion in hospice, but that was by their choice, so 100% dying in their preferred place of death. Next slide. And of course, then when you're trying to persuade people that what you're doing fits with the costs of what you're providing becomes very important. So we knew that patients liked our service and we knew that they wanted it to continue, but we then had to persuade people, particularly in the health board, that we were worth funding. And so we did opportunity costings, and we chose 15-day treatment episodes because on average we reduced the amount of time that patients spend in hospital by 15 days. And if you look at the cost of a 15-day admission by standard care, it comes to about just over £11,000. Our model is just over £1,000, so cost effective as well. Next slide, please. And if you project then looking forward, as we've expanded our service, we're on track for saving around 3 million in 2020, which obviously amounts to a lot of bed days, a lot of services saved for other people coming into hospital. Next slide, please. So the key elements of creation of the pathway really was really central was the compassionate approach. So right from the start, we were talking about rapport building and trust being absolutely central to what we were doing, and how important that is to patients, particularly when you need to talk to them about the life-limiting nature of their condition, and helping them plan going forward in the last phase of their life with an uncertain prognosis and the fears that that carries. Very important interspeciality relationships. They've built strong bonds with the team who are referring to us, and it's very, very important to respect that, because patients are frightened and they don't want to be taken away from cardiology services and active support that may increase their survivorship. They want, but they need us as well. So looking at a coordinated, flexible approach to fit their disease trajectory better, which palliative care as a speciality generally was not doing very well, as I mentioned at the beginning, and cross-boundary working to reach the patient wherever they are, and to take the expertise of the cardiology heart failure team out to community so that patients weren't needing to come in to get that expertise. We were helping to take it out as they spent more time at home towards the end of their lives. And true collaboration with patients and carers and interspeciality and with all stakeholders in creating our pathway so that it was achieving what we wanted, which for patients and what they wanted. And individualised care, really just making things as bespoke as possible so that patients are treated as individuals. So not expecting them to just fit into the services as we created them, but creating services to fit in with them. And the sorry, I was just going to the last point, yeah. The great opportunity for interspeciality learning so that all the time you've got a synergistic value to the two specialities coming together, which just makes what you're providing so much better.
Thanks, Clea. I think you've just given us a very good example, walking rapidly through your data of how to create a patient-centred care pathway. And some of those statistics are quite compelling in terms of what matters to patients along their own journey, and also what might matter more to health boards who are trying to plan at population level for the provision of care for wider numbers of patients than just the individual. So it's compelling data, and I know you're trying to and having some success spreading it across Wales. I just want to ask you before we move on to a few more questions, what's the biggest barrier that you see to spreading this and the work and the expertise that you have gained in this, and with that barrier, what might be done about it?
have to say that at the moment we're not having too much trouble with barriers in terms of spreading, and I think that's probably because it's so compelling that this is what patients want. And at the end of the day, when you're trying to provide something within a health service which should be about patients, people find it very hard to argue with. And the fact that it happens to be very cost effective at the same time is the magic answer, really. So we haven't really had huge barriers. We're managing now, if we go on to the next slide, I can show you, we're managing to spread across 3 health boards: West, Hywel Dda, Swansea Bay and Cwmtaf. Powys were initially looking at this, but for resource reasons that currently are not able to take that forward. But Betsy Cadwaladr are also interested in adopting for heart failure, and we're also got interest in spread to other non-cancer life-limiting conditions as well. So in Cardiff and Vale, we're now looking at advanced renal disease and adult congenital heart disease, and Swansea Bay are interested in looking at advanced respiratory. We also got interest across in Bristol for the heart failure pathway, and I have to say it's really just selling itself without really. I mean, it's been very important to get it out there, but obviously it's when you're a clinician and you do the job, as I'm sure you well know, Sue, when you're doing the job because you care about patients, it makes you so enthusiastic about something that so fits what they want. You know, we rarely get people not turning up for clinic, so all the time, and they're so appreciative of what we're doing, and that you know it sells itself.
Great, that's really good to hear, and I think you've just shown that again, a demonstration of why better data is key to patient-centered care, because you're telling us it engages other clinicians, it speaks for itself, for the patients and for clinicians and health boards. So you've just demonstrated the very point we're trying to make. I just want to give one comment from Alan Wardlaw, who, as you know, is one of our digital specialists in Wales. It says that the forthcoming National Clinical Framework makes collection of PROMs and PREMs, so patient-reported experience measures, at scale central, and using these data to allow the system to learn what works and what doesn't. A key foundation will be a modern, robust and flexible digital architecture and the analytic capability to turn the data into information and knowledge. So obviously extremely important that we've got the backup of the digital capabilities. And just touching on that, this question actually is back to you, Wayne, I think, because we're probably reaching the end of this this interactive panel, but it's one about it addresses the issue of comorbidities. So a question from Angie that says PROMS use is evolving with COVID and has increased during COVID. However, we need to bear in mind that patients do not just have one condition or event, and may therefore be asked to have multiple accounts, apps and questionnaires. So should we be thinking of a more joined up approach? And I'm guessing we could have an example today of someone who's got inflammatory bowel disease and lives with heart failure. How can you combine those two PROMs and follow them?
Yeah, my honest answer to that is I don't know how you do it, but I think you have to. You can't have somebody with like 17 apps on their phone.
Mm-hmm. Yes.
We'd have to, we'd have to think about how we make it easy, how we make it meaningful and relevant, but how we do that. As I said to you, Sue, I couldn't answer that.
No,
but yes, we do have to think of that.
It may be that Alan might have more insights than the National Clinical Framework, but I think it's true, isn't it? With increasing an aging population, we don't have conditions with patients with a single condition anymore. We have patients living with several chronic conditions. So
I think what was interesting coming out of the research done by Stuart Bloom around COVID and the BSG app was that patient-entered data where they had comorbidities was more accurate. Mm-hmm. Because they were able to enter all that data, whereas you would have had to trawl through numerous hospital records probably to get that data.
Yes, so that's maybe a challenge for our digital colleagues and those on the PROMS team. So anyway, it's just left to me to say thank you to our expert speakers this evening. We've had some great slide presentations, some compelling data and some superb insights into why better data is key to patient-centered care. We've also identified some issues that need working on going forwards. But I think we just demonstrated in this small window of opportunity how useful this work can be, how it engages patients and really is the way forward, so that we're not just dictating, we're actually co-producing care with patients and co-designing it and really doing what matters for the patient along the journey. So thank you to everyone who's been our speakers tonight, to Wayne, to Claire, to Sian. Thank you to our backroom team of Alistair, Laurie, Sarah and Pritha from the Life Sciences Hub. Thank you to our delegates for attending as the evening is drawing on. Please check in with the rest of these sessions in the Value in Health Week. We're only on day 2 of 5, plenty more to come. Thank you very much.